Okay, welcome everyone to ASJ GEMS. We're back here in the new year with Dr. Mark Mofid presenting on update in surgical site infection prevention. Dr. Mark Mofid is a clinical professor of plastic surgery at the Johns Hopkins University School of Medicine and has dedicated the last 20 years to improving surgical outcomes for patients. He's a diplomat of the American Board of Plastic Surgery, the American Board of Facial Plastic and Reconstructive Surgery, a fellow of the American College of Surgeons, and was an associate professor of plastic surgery at the University of California, San Diego for over a decade. He received his undergraduate degree magna cum laude from Harvard University and completed his medical degree and training at the Johns Hopkins School of Medicine, has presented his research at more than 40 national and international conferences, and is the author of the most cited publication in the field of plastic surgery. And what journal is that in, Dr. Mofid?
That's the Aesthetic Surgery Journal.
That's the Aesthetic Surgery Journal, exactly. He's published more than 25 original research articles and book chapters, and has been a surgical innovator throughout his career and developed novel techniques for breast surgery, facial surgery, abdominoplasty. More recently, he invented the first naturally sourced and hypoallergenic dressing for the market called Silk with a Y, and he currently holds 3 patents. Welcome, Dr. Mofid.
Thank you, Phaedra. Well, first of all, I want to make sure everyone can see my screen. Phaedra, is the screen showing with the first slide?
It looks good. I think you wanted us to go ahead and start with some polls.
Yeah,
I'm gonna run the first one. So if everyone could respond to the polls, we're switching up a little. Normally we run these at the end, but like any good presenter, Dr. Mofid wants to know his audience. So we're gonna ask you to take a couple minutes here, respond to the polls. And usually I wait till we have 50% participation or thereabouts. And this first one is asking about the most effective intervention according to the CDC, SKIP initiative for infection prevention. So thanks for everyone. We'll take just a few seconds here. And I think that this is an important question and kind of a good baseline for us to jump off, right, Dr. Mofid?
Yeah, I mean, this really tells the whole story. I think this one.
Okay, we're at 41%, so we're just going to wait another couple of seconds. 46%. 48. Oh, there we go. 51%. I got my druthers. Okay, so let me share these results here. And you can see that 50% are saying administration of prophylactic antibiotics, including time selection and discontinuation.
Okay.
Is that what you would have expected?
That's pretty close.
Okay. Excellent. We are going to now launch poll number 2. And thanks again for participating. Here we go. We're asking, what kind of dressings are you currently using? Okay, Dermabond is in the lead at the moment. Oh, SteriStrip's taking over now. Just 5 or 6 more seconds. Everyone can weigh in. Okay, we'll call it there. So it looks like a tie between Dermabond and SteriStrips.
And the conventional tape and gauze.
Oh yeah, that's right, exactly, down there, right, conventional tape and gauze. Okay, last one, and thanks for hanging in there with us, everyone. Here we go. We're asking about how many plastic surgery meetings you've attended where there's been an SSI prevention panel. I think this one might surprise you, Dr. Mofid. Well, let's see. The numbers are coming and going here.
Yeah.
I'll give it 5 more seconds. Okay, here we go. Okay.
All right. So for the majority, it's between 0 and 2. It looks like, with the majority between 1 and 2. All right. Yeah. Good. Well, I suppose I'll just get right into it. If you want to remove the poll, I can get started with the
Oh,
presentation.
actually, I did. It might just be on your screen if you can click out.
Oh, I see. Okay, so I can exit out. Okay, very good. All right. Well, thanks for that introduction. I I've had an interest in patient safety really now for, the better part of my career. It started with, there's a lot of different things. Obviously, the paper that was published in the Aesthetic Surgery Journal 6 years ago, 7 years ago, I think now, was the one on fat grafting safety. This is now, in my mind, with 20 plus years of experience in practice, I'm on the other side of the age of 50 at this point. And I can tell you that the most significant complication, the largest complication that exists in the entire field of surgery is surgical site infection. And I think that having that at the forefront, just recognizing what the biggest problem that really faces every surgeon in the United States, including every plastic surgeon, is that we get surgical site infections. So everything else that I've ever worked on seems minor compared to this. And, I know a lot of effort has been put in on the federal level and on the state level for surgical site infection prevention and safety, but not a lot of us know much about it. The majority of participants, at least on this panel, have attended at most, 1 to 2 presentations on this over the course of their career. So I think that it's worth talking about, and it's worth having more panels at national meetings, really to teach us how to take care of and how to prevent the most common complication that exists in plastic surgery. All right, so it's my I'll tell you this, as really my first slide before you see everything else, that it's my impression. I just want you to know this is my bias going into this talk, is that modern surgical dressings are a combination of charlatanism, witchcraft, and antiquated technology. And, I'll go over each of the dressings that most of the participants, at least on this panel, are familiar with using. It's really shocking to me that in the year 2024, we are, using high-tech smartphones. We drive cars that are either automated or electric. We've got tremendous technologies outside of medicine, and then within medicine, we have robotic surgery. We have all these protocols. I mean, if you're an internal medicine doctor and a patient comes to you with new onset hypertension or diabetes, there's a protocol to follow. Whereas when it comes to surgical site dressings, it's a free-for-all. Everyone on this panel that's a surgeon uses a different technique. And it's not because, we intend to do it that way. It's just that there's no standardization. No one has instructed us that one dressing is better than another, or that you should, shower patients or not shower patients, or how long you leave a dressing on. It's quite literally a free-for-all. And it's my opinion that it's the most important intervention that exists to prevent surgical site infection. So, for me, this is a big head scratcher, why there's no standardization within our system about which technologies work, which don't work, and frankly, which are dangerous, because there are some dressings that are commonly used that I consider at this point to be dangerous. The big picture is that of all the operation, of everything that we do, I told you it's the most common complication that exists in field of surgery and plastic surgery. It affects SSIs, affect 2 to 5% of all surgical inpatients in the United States. The average cost of a surgical site infection when it occurs is $20,000. Now, that's obviously, there's a big range there. If you have a patient that had a breast reconstruction with a tissue expander or an implant, and they wind up having an infected implant, it's an additional, several days in the hospital, an additional surgery to remove the infected prosthesis, and then go back in and redo it. It's going to be $20,000 or more. There are certain operations, for example, one of the orthopedic surgeons that I was speaking with recently told me that the average cost of a periprosthetic hip joint infection So basically, when they do a hip replacement, if that gets infected, the average cost is $300,000 to the healthcare system. And that doesn't even include the cost to the patient, time off of work, family members that have to leave work to help care for them or provide care for them, driving back and forth from a physician's office, your time to take care of the patient. The annual cost to our healthcare system is $10 billion annually. There are more than 90,000 readmissions per year in the United States attributable to SSIs. It can increase hospitalization stays up to an average of 11 days. So it's a big problem. And the fact that, most plastic surgeons on this panel have, at most seen one or two, the majority, I think, have seen none. I've never, in 27 years of training and being in practice, I've never attended a single panel on surgical site infection prevention. It's the most important problem that exists. All right, so these were the primer questions. I can tell you that the majority of participants got this answer wrong. You'll have to listen to the rest of this talk to find out why you got it wrong. Here's the second question. And this is a very interesting slide to me. You'll notice it's a pretty small list. There's not a lot of dressings that are out there. You basically have silicone adhesive dressings like Meplex. You've got the cyanoacrylate dressings, basically Prineo Dermabond, Exafin and Liquiband, or just plain Dermabond. Steri-strips are made by the 3M company. There's obviously they're off patent 42 years ago because they came out 62 years ago. Hydrocolloid dressings like Aquacel with or without silver impregnation, and then just tape and gauze. I mean, this is Civil War era types of post-operative dressing regimens that in some cases are going to be the majority of the dressings that are used across specialties. So to start out with, an SSI is basically an infection that occurs within 30 days of the procedure or within 90 days if there's an implant. So, just to give you a definition, an SSI occurs when it happens within 30 days of the time of surgery, typically as long as an implant's not being used. The incidence varies across specialties. Obviously, you would expect gastrointestinal surgery to have the highest infection rate, but it's between 2 and 5%. And again, some of these, for us, if I have a patient that gets a surgical site infection, it develops into a wound, it's kind of a nuisance as long as there's not an implant involved. If an orthopedic surgeon, a cardiac surgeon, or a neurosurgeon, especially if there's hardware underneath, like a spine surgery case, develops an infection, it's catastrophic for that patient. 24 years ago, CDC and Medicare created a program called the Surgical Infection Project, which was designed to basically find out what the most effective strategies were to decrease the risk of surgical site infection. They formalized it into the SCIP initiative, which is the Surgical Care Improvement Project in 2006. And the goal there was pretty lofty. It was to decrease the risk of SSIs by 25% by 2010. And they used largely the Cochrane reports. It's a nonprofit based out of the United Kingdom in order to identify 6 methods based on randomized controlled trials. And they wanted to make sure that these were meta-analyses and very large trials that, had good controls, were basically level 1 or level 2 evidence. And it's basically uniformly regarded as an absolute failure. This country has spent, billions of dollars getting the word out on what these SCIP initiatives were. And if anything, the rates of surgical site infections have actually been going up steadily every year by about 3%. The first SCIP initiative has to do with antibiotics. You're supposed to give antibiotic prophylaxis within 1 hour of incision. If you do that, it decreases the rate of surgical site infection from 7.4% to 3.4%. If you miss the mark and you give the antibiotic after the incision is made, you're more likely to get an infection. And if you give it more than 2 hours prior to incision, you're up to 5 times more likely to get a surgical site infection. You have to choose the right antibiotic. It's basically for the stuff that we do as plastic surgeons, a first or a second generation cephalosporin. If a patient is allergic to cephalosporins, not penicillin per se, but just cephalosporins in general, you give either vancomycin or preferably clindamycin or fluoroquinolone to prevent large-scale antibiotic resistance to vancomycin, which we don't want. You're supposed to stop the antibiotics within 24 hours of surgery. You know, when I was in training, we would typically administer antibiotics for up to 7 days after surgery, or as long as drains were in. There's very little evidence for that. Since there's basically no evidence for that, as a national initiative, again, to decrease the risk of antibiotic resistance, as well as Clostridium difficile, the idea is to stop antibiotics within 24 hours. So this is actually one of the SCIP initiatives. I kind of bundle them all together as antibiotics. The next one has to do with maintaining a tight glucose control of less than 150 in diabetic patients. By doing that, you decrease the risk of surgical site infection from 16% to 9.4%. You shouldn't razor a patient. You should only clipper them. You decrease the risk because of obviously injury to the stratum corneum and the epidermal barrier, which puts us at risk of infection. So you can decrease the risk of infection from 4.4% to 2.5%. And for those of you who answered antibiotics, that's what I would have answered had I not, done the research myself. But normothermia is the most effective technique, according to the SCIP initiatives, of preventing surgical site infection. It decreases the risk from 13% to 4.7%. So not freezing your patient in the operating room is actually the most effective way to prevent surgical site infection. And here is just a slide showing that there's a 64% reduction in SSIs by maintaining normothermia. Second would be getting the right antibiotic in within an hour of surgery, and stopping it within 24 hours gives you a 54% reduction, followed by not razoring, but clipping your patient, and then maintaining tight glycemic control in diabetics. Along the lines of the witchcraft in medicine, I'm guilty of using bacitracin powder in my irrigation fluid, and I did so for, let's call it 25 of those 27 years, up until the point that I think the FDA was so fed up with the fact that there was no evidence for using bacitracin powder other than giving certain patients anaphylactic events. And so they actually requested manufacturers to voluntarily remove bacitracin powder from the market in its entirety, because there was no benefit to using it in any situation. And they did that in January of 2020. The fact that it took us, probably 30 to 40 years to figure this out is really kind of shocking. There is good evidence for using chlorhexidine and alcohol-based prep solutions as opposed to betadine. You do that, it decreases the risk of surgical site infection from 7.28% to 5.06%. So that represents a 30.49% reduction. It does look like there is a lower relative risk of 0.57 of using antibacterial irrigation compared to non-antibacterial irrigation. These are large meta-analyses, and there's no standardization of what that antibacterial regimen is. In some cases, it's basically Iricept or chlorhexidine-based solutions. In some cases, it actually has antibiotics in it. Again, to sort of reiterate the fact that it's kind of a free-for-all. I know there's some surgeons on this panel that don't let patients shower for the first few days after surgery. Some patients are very aggressive about getting patients in the shower. There's basically no difference in SSI rates when patients shower within 12 hours or waiting over 48 hours to shower. So if there's ever been a study that's been done showing that you shouldn't shower, I'd be very interested in seeing it. I couldn't find any evidence that showering or not showering makes a difference. It's always been my personal preference to help patients get into the shower. For many of them, it just makes them feel better. The one glaring deficiency in the skip initiatives was that the Cochrane reports never really found that there were enough high-powered research studies to show that which dressing you use or what type of dressing that's used decreases SSIs. That doesn't mean that the type of dressing or the postoperative dressing regimen doesn't matter. I think it's actually the most important of all of the interventions that we perform as surgeons in order to prevent surgical site infection. I just merely want to say that the SKIP initiative, basically the CDC and Medicare together, were never able to put together enough studies, large meta-analyses, in order to show that there was a difference. Medical adhesive related skin injuries affect about 1.5 million patients per year. Most of us aren't, even though we see it basically every day or in our own practices, we don't, necessarily quantify it in any way. I don't know of a single hospital system that actually reports skin injuries as a result of the surgical dressings that we use. You're going to see some slides in a little bit having to do with cyanoacrylate, but I would like to talk a little bit about the use of cyanoacrylate as a surgical site dressing. But it can occur with hydrocolloids like Aquacel. You're basically stripping off the top layer of the stratum corneum. It's a very strong adhesive, and that has its own set of problems. Obviously, for those of you who are familiar with using steri-strips, you know that certain patients can blister as a result of, it's an inelastic dressing. And so with postoperative swelling or motion, it can actually shear the top layer of the skin. But none of us really even keep track of it. And as far as I'm aware, there's no registry either on a national or a state level or on a hospital-based level to actually track how these skin injuries occur and with what frequency they occur. Let's see. Okay. So, the most common cyanoacrylate dressing, there's multiple manufacturers that make cyanoacrylate. One of them is obviously the Ethicon division of Johnson & Johnson. The other would be Commence. It's a smaller company outside of, it's in Georgia, originally UK based. And then there's Medtronic, which makes Liquiban. So there are a number of different manufacturers of cyanoacrylate technology. And the concept is not new. It goes back to basically the Vietnam War when cyanoacrylate was first used to take care of wartime injuries. It was officially FDA approved, during my career. I started my training in 1997, and I remember when people started using Dermabond technology on the wards, largely in the emergency departments initially, and then to actually cover surgical sites. And over the course of the last 26 years, I can tell you we've spoken with the manufacturers of all of the makers of cyanoacrylate products in the United States, at least the major ones. And the rates of allergic contact dermatitis are going up significantly. It's thought to be a result of sensitization. One of the executives at, one of these large multi-billion-dollar companies told us that they've, kept track of complaints that they have to report to the FDA through the MOD database, and that in many cases, the more prevalent cyanoacrylate is in that community, and the longer it's been in that community, the higher the rates of allergic contact dermatitis. And that's coupled with the fact that in many cases, this is a two-hit phenomena. A patient that has never seen cyanoacrylate before, meaning has never had it applied to them, will have a lower risk of allergic contact dermatitis. And if it's ever used again in a subsequent surgery, they have double the risk, so a much higher risk. And I'll go over those exact numbers in just a bit. Ethicon introduced the Dermabond Prineo system, which is basically a polyester mesh with an accelerator, and coupled with the cyanoacrylate, the 2-octyl cyanoacrylate, it results in a very rapid curing of that glue. And again, severe allergic reactions. It's painful to remove. It often, I shouldn't say often, in my personal experience over 10 years, it always required a chemical solvent. We used Detachol in order to remove the black tarry goo that was left behind. It's messy to apply, obviously messy to remove. So this is the mod database. So anytime a manufacturer receives a complaint, it requires an investigation, and we just this is an FDA, this is a database that everyone can access. Everyone on this call certainly can access. And we found 1,504 adverse events that had been reported by surgeons to industry, and then industry subsequently reported those to the FDA. So as of November 2023, there were 1,504 adverse events. Now, the actual number of adverse events is likely drastically underestimated here. I don't know how many of you on this, on this panel have ever reported to industry an adverse event. I can tell you, as someone who's done 2 clinical trials now, and has 10 years of experience with cyanacrylate technology, and specifically with the Perineo Dermabond, I've never submitted a single complaint. That doesn't mean that I haven't had hundreds, if not, maybe 1,000 patients of my own over the course of the last decade plus that have had problems. I'm just saying that this is an absolute underestimation of the actual adverse events. Virtually all of these adverse events were allergic contact dermatitis. And this doesn't actually even include Dermabond. This is just the Dermabond Perineo system. So the actual adverse events with Dermabond itself would probably number in the tens of thousands as opposed to 1,504. This is typically what you see with cyanoacrylate polyester mesh technology. Typically, it starts out with itching, followed by erythema, either as a result of the polyester mesh accelerator, or in some cases, we would find that wherever the Dermabond, it's a liquid after all, sort of spills around the skin site, maybe it's the Dermabond itself. So it was always either one or the other, or a combination of the two. And obviously you have to remove it. The downside is that when a patient develops allergic contact dermatitis, they're actually at significantly increased risk of surgical site infection. The national average is about 7, it's more than 7 times higher. So if you have a patient that develops allergic contact dermatitis, their risk of surgical site infection goes up 7x. Here are more photographs. These were all taken as part of a clinical trial that we had done here in San Diego. It was an IRB-approved clinical trial, and this was actually published in the Aesthetic Surgery Journal Open Forum, I want to say 3 months ago or so. I think it was in October. Here are infections. It should be no surprise that, for a breast procedure, for example, if you have a patient with significant allergic contact dermatitis, it almost always goes on to triple point separation. That's actually the point of maximum tension and ischemia, if you will. This is nothing new. The people who I think, I would say the specialty that are, most on the ball on this are really the orthopedic surgeons. The fact that, in 27 years, I've never attended a single panel as a plastic surgeon on SSI prevention. I can tell you that orthopedic surgeons always have a panel at meetings on surgical site infection prevention, largely because of hardware and or prosthetic joints. For them, it's a catastrophic event. In some cases, if a patient develops an infected knee prosthesis, it could result in an above knee amputation. So these skin sensitivities, are known. There was a publication in the Journal of Pediatric Orthopedic Surgery that found that repeated exposure to Dermabond increased the risk of allergic contact dermatitis. So for patients that did not have a known previous exposure, the risk of allergic contact dermatitis was 12%. For patients that had a known previous exposure to Dermabond, the risk was 24%. So it basically doubled the risk of allergic contact dermatitis. And that study was done at Harvard Medical School. This study came from Michigan. This is from a study that had looked at, several hundred patients that had one of the two major cyanacrylate technologies, either Dermabond Prineo or Exafin Fusion. This was a retrospective study. And the shocking number here, not so shocking if you look at the outcomes that we published in the Aesthetic Surgery Journal Open Forum in October, but the risk of having a superficial and or deep wound complication using the Dermabond Prineo system was 57%. It was 40% with the Exafin Fusion system, not far behind. That difference was not found to have a significant p-value, but these are big numbers. More than 1 out of every 2 patients that has the Dermabond Prineo system applied to them is going to have a superficial and or deep wound complication, at least in orthopedic surgery. This is a paper that was published in 2000. Actually, I think it was submitted in 2019. It was published in PRS in 2020 from Virginia. They looked not at the Dermabond Prineo system, but just Dermabond. And they looked at 102 consecutive breast cases. And what they found was that there were 14% of patients developed allergic contact dermatitis. It was confirmed by scratch testing, which means this was a good study, confirming that it was a reaction. And every patient that was allergic to Dermabond also had a scratch test looking at Exafin and Liquiband. So they just wanted to see if there was cross-reactivity, and in every case that there was. The moral of the story, at least for the authors who published this paper, was that you shouldn't use Dermabond in plastic surgical procedures. And if you looked at the previous slide, you probably shouldn't use it in orthopedic surgery either. We published this paper only 3 months ago. We basically found we had similar findings. The idea was that we had created a novel dressing. Really, the technology itself is not so novel. Silk has been around for as a textile for 7,000 years. It's been around for medical purposes since like 2000, or I think it's 1200 BC or 2000 BC. So it's been around for about 3,000 years. They find it in mummies in ancient Egypt. It was sort of reintroduced in ancient India, and then again during Roman times, where they used silk sutures to suture Achilles tendons in gladiators. So silk technology has been around for a long time. If you're old enough to to remember, silk sutures have been around for a long time. The problem with silk as a suture is that silk is a combination of 2 different proteins, sericin and fibroin, and the sericin protein can cause allergic skin reactions or allergic reactions in general. So what we endeavored to do was to strip off the top layer of that of each silk strand, which is the sericin protein, and just leave a pure fibroin core, which has a very low to zero risk of allergic contact dermatitis. And so we published this. I think that I've heard that this is, I'm not 100% certain, but it's the highest scoring, altmetric scoring paper published in the Aesthetic Surgery Journal Open Forum to date. We went ahead and commercialized this. Again, the technology is not new. If you recall the Seri mesh that Allergan had introduced about a decade ago, it's basically similar technology. The sericin protein is removed. The only thing that we did is repurpose it and apply a pressure-sensitive adhesive that is waterproof and non-immunogenic, and is similar to Post-it note glue, so that there would be no adhesive residue when it's removed. So it's a woven silk fibroin mesh with a hypoallergenic acrylic adhesive, a peel-off paper backing. Again, we strip off the sericin protein. This is not proprietary to us. It had previously been done, and just patented it with a couple of United States patents and a few either issued or pending international patents. to repurpose it for laceration treatment as well as surgical site wound closure. We happen to manufacture in northern Italy. There's really only a few places in the world where this can be done, but everything is manufactured, sterilized, and packaged in the United States. The benefit of mesh technology is that it adheres over contoured surfaces such as joints. It's meshed, so there's some stretch to it. It doesn't cause blistering. And again, it's waterproof and takes seconds to apply and seconds to remove. We had looked in 2 different clinical trials. The first one was published in the Aesthetic Surgery Journal Open Forum. We have a second paper that's going to be published, I think, in June, although it's going to be online earlier in a different journal. But we looked at the current standards of care. And since the majority of you are using either Dermabond Prineo or Steri-Strips, we looked at it with those. I don't want to steal the thunder of the next paper that's coming out, but I can tell you that there was very favorable data generated, almost identical to the data that was generated with the cyanoacrylate product. We looked at 5 postoperative visits over 6 weeks, and what we found is that it's a more comfortable dressing. No one got a rash here. I'm not saying that no one ever will, but in our study, we never found anyone with a rash. And in my own personal use, I've used hundreds and hundreds of sheets of this. We have orthopedic surgeons that I think we had. I got an email yesterday that someone's already done 110 hips and knees, prosthetic joint replacements, 0% allergic contact dermatitis, 0% surgical site infection. None of our patients required antibiotic intervention, whereas with the cyanoacrylate product, it's uncomfortable. 24% of patients had a severe rash, and the majority of those patients required antibiotic intervention. We found that if you get a rash at least with cyanoacrylate products, there's an 85% chance that you're going to go on to develop an infection. Again, a split study. These were published in the Aesthetic Surgery Journal Open Forum. This is looking at Dermabond Prineo on one side and the prototype that we had used on the other. This happens to be 11 days postoperatively. What usually starts out as, questionable allergic contact dermatitis, possible cellulitis, putting a patient on antibiotics often will split open and result in a big wound, which happened to this particular patient. We found much higher rates of triple point separation in our breast reductions. A little over a third of our patients that were treated with cyanoacrylate had developed triple point separation. I think it was 8 or 9% of patients with the silk bioprotein prototype had developed triple point separation. Obviously, no rates of allergic contact dermatitis. 50% of patients that had the Dermabond Prineo system put on, I think it was 52% of patients required some sort of medical intervention, meaning either topical steroids or oral antibiotics. Very similar to what the orthopedic surgeons found. More than half of all the patients in this study had to go on an oral antibiotic or a topical steroid because they had cyanoacrylate applied. In my opinion, using nothing, just using the Civil War era tape and gauze is better than using cyanoacrylate. I've completely moved away from cyanoacrylate, as many other people obviously as well. Steri-Strip technology was introduced in 1962 by the 3M company. What never made sense to me about, I'm not just talking about the 3M company, McKesson makes a SKU of it. This has been off patent now for 40 years, is that inelastic paper or rayon products, they either make it out of paper or they make it out of rayon, doesn't contour to 3-dimensional surfaces. It's not waterproof. Every wound creates an exudate. If you have a wound exudate from underneath, basically causes the Steri-Strip to come off. I can tell you that in a subsequent study, we found that 75% of the time Steri-Strips fall off within a week. 90% of the time it falls off within 2 weeks. And there's really only 2 things that can happen by using an inelastic dressing, either with swelling or motion. Either it's going to fall off, which happened 90% of the time within 2 weeks, or it's going to shear the skin and you're going to get a blister, which we found happens 10% of the time, at least in our study. It's not water resistant, prematurely detaches, you get blisters. I don't get it. We have robotic surgery, we use, gene therapy, we drive electric cars and we use smartphones, but we're using a technology that came out 62 years ago that's not even good. The data that we have on surgical site infection, obviously, when you do a breast reduction, that's 70 centimeters of incisions. If you do a tummy tuck, it's 40 centimeters of incisions. 120 centimeters of incisions, trying to cover it with steri strips will take you 10 to 15 minutes to apply in the operating room. And for many of us, we're trying to keep it on because it always falls off using mastisol or benzoin, which has its own problems. Those are not benign products either. And so, there's a subsequent follow-up article that was published in PRS 2020 saying you shouldn't use mastisol or benzoin either, just because they're, problematic products. Blistering, all of us have seen this. Again, it makes sense that if you swell, which everyone does after surgery, especially after a breast procedure, one of two things happen. You either shear the epidermis from the dermis, causing a blister, or it falls off. There's only two options there. So here's premature detachment, steri strips. It should be no surprise that if you wind up having an uneventful postoperative healing course, meaning no surgical site infection, no allergic contact dermatitis, no blisters, no triple point separation, you're going to wind up with better scars. So even though it wasn't a clinical endpoint of our study, what we found is that there were much higher rates of hypertrophic scarring, thicker scars. Many of these patients that were part of these studies are now 2 years out, and we find better scars as well. And so it's just one of these obvious things that if you don't have a postoperative problem, you're going to wind up with better scars. We're currently starting a clinical trial at Hopkins on that. So the national average, if you do a meta-analysis, is that allergic contact dermatitis disrupts the epidermal dermal barrier. It increases the risk of surgical site infection by 7.19x. We found in our studies that if you get allergic contact dermatitis, there's an 85% chance you're going to get a surgical site infection. So it's very important to avoid allergic contact dermatitis or any sort of skin injury during the postoperative wound healing course. I want to just share sort of an interesting trick with you all. One of the things that I have never enjoyed doing is applying a drain site dressing to a patient and trying to take care of it postoperatively. So I'm one of those surgeons that doesn't use drains on breast reductions, but I do use them on abdominoplasties. They stay in for, usually a week or less. If I do a breast reconstruction, at the time of the mastectomy, almost always a drain is put in as well. And there's no good way to cover it because a patient that showers after surgery, any sort of absorbent dressing is going to get wet. And if you try to fix it with Tegaderm, it's going to basically be disrupted as well. And so I've never found a good drain site dressing that I like that's waterproof. Silk happens to have, is hydrophobic, meaning that it doesn't absorb any sort of fluid or water. And so it doesn't hold on to fluid in a way that it would allow bacteria to grow. So it dries off just like normal skin. It's kind of one of these very unique properties of silk. And so what we do is we Roman sandal the drain, or at least cover it sort of in both different directions. You can either use drain sutures or not. If you carry the tail of the split ends, once you bisect the dressing, you can follow it up along the drain and you won't actually have to apply the drain stitch. So we found that it's a very effective technique. I think that as far as R&D goes, that's what I'd really like to see. All the major manufacturers do is create a better drain site dressing because, I haven't found a good one that I like. So this is, again, this product has now been commercialized, and, we made it available in early December. We're, very excited about a number of different clinical use trials that are in place now at some of the largest academic centers in the United States. And I appreciate your time. Thank you.
Fantastic. Thank you so much, Dr. Mofid. I'm going to run a poll that I put together while you were talking about reporting to adverse events to MAUD. So
Yeah.
I found that interesting, and I think let's take a second here while we're starting to debrief about what portion of our audience here has done that. So we'll let that run for a minute or two. And I'm going to kick off with a couple of questions from the chat box. So starting
Sure.
with Fuad Samaha is asking, what about nasal decontamination of patients and of surgical staff?
Very effective technique. I could have put that up there. Orthopedic surgeons almost uniformly will use povidone iodine or another type of nasal swab, but it's a very effective technique to decolonize the nares. Yeah, I appreciate you mentioning that. I'll put that in the in the next set of slides. But it's a very effective technique, and again, it's very commonly used for joint replacement amongst joint replacement surgeons.
Okay, and then Ken Francis is saying he finds it convenient and disingenuous to blame Dermabond for things like wound dehiscence. Were there control arms in the orthopedic studies cited if you know this information?
Sorry, here, show me here. Let me see if I can find the chat box. If I can find that, because I'm not sure I understood the question. What was the question? Oh, here.
Well,
Okay, it says I've convened disingenuous to blame Dermabond for things like wound dehiscence. Were these control arms in the orthopedic studies cited? Well, these were one of them was a retrospective study, one of them was a prospective study. I mean, if you have an issue with the way the studies were done, I'm sure that I've spoken with the authors of both of those studies, and I have no reason to doubt them. But it's not isolated to the orthopedic literature. It's been published now in the plastic surgery literature as well. And I'm not blaming the company that makes Dermabond. I mean, it's obviously being used by several different manufacturers. It's just that the prevalence is increasing. We had a conference call. Again, there's only 3 major manufacturers, and the executives from one of the companies, very large billion-dollar company, contacted us and asked for a conference call with us. And basically, I'm not covered by an NDA with them, at least not right now. Basically, let us know that the rates that they're seeing of allergic contact dermatitis are increasing, that they're alarmed by it. We spoke with, we're at the American College of Surgeons, and one of the other multi-billion-dollar companies, their executives approached us as well, and they're finding exactly the same thing. So, I'm not the first person to talk about it. I'm certainly not the first person to publish on it. I'm reporting it. I'm reporting it.
okay, let's move on to the poll here. So only one person out of 18 who answered has reported an adverse event. So that makes it 6%. It looks like 1 out of 18. So surprising, not surprising?
If I had to answer this poll, I've never reported an adverse event to industry. And that's my point, is that if there have been 1,504 complaints through November of 2000, and let's say that 6% of all surgeons have reported it, but 94% haven't, then that actual number is probably 50 to 100,000. There should be 50 to 100,000 reports of problems. And I think this might even be overstating. I think the vast majority of surgeons have never reported their complications. Certainly not surgical site infection. Certainly not allergic contact dermatitis. To the MOD database or to industry.
Okay.
It's just not on our radar. We just don't do it.
Right.
We should.
Okay.
Maybe going forward I will, but we don't.
And I did put a link in the chat box for anyone who wants to look into that. Next from Robert Hardesty, he's asking, can you comment on preoperative decolonization?
Again, I think essential. I think that decolonizing the nares has been proven to be effective. There are multiple studies that support doing that. As far as skin decolonization, it's part of our regimen to do chlorhexidine. Again, it's been found to be effective in the operating room. So we start patients 24 to 48 hours ahead, virtually all breast and body procedures with the chlorhexidine rinse. It's part of our standard regimen, and I would encourage you all to do it as well.
Okay, sounds good. Daniel Ledzinski is asking, does serial exposure to fibroin lead to immunogenicity?
So we don't believe that there's any data in literature where, I didn't invent fibroin, it's been around for the idea or the ability to strip off sericin from silk has been around for at least 20 years, maybe even longer than that. We do it, and it's now used in ophthalmology, it's used in joint surgery. There's a wide variety of uses. To my knowledge, there has never been a single report of a fibroin allergy ever published in the literature. We never found it with our own, studies. I've never found it myself, amongst any of the patients that I've operated on. None of the orthopedic surgeons, we have a large academic center in Southern California. I won't use the name of the institution, that has completely switched away from cyanoacrylate and is now just using silk fibroin adhesive technology to cover all of their joint replacements. If it exists, I'm not aware of it, nor have I ever encountered it.
And let's see, we've got a question here about comparing cost to Prineo and Exafen.
Yeah, it depends on obviously whether you're on a GPO. Some of the hospitals, again, I'm not covered by an NDA with any of the hospital systems, so I'll tell you, but my understanding is that, first of all, what our surgery center was paying for, my nurse is just behind me, so she can correct me if I'm mistaken, but what our surgery center was paying for the Prineo Dermabond system, the 60 centimeter skew, and we were purchasing it right off the website, was about $167 per applicator. It was about $120 per applicator for the 22 centimeter skew. HPG is the largest, or one of the large GPOs with hospital systems, sells their 22 centimeter skew, or the price, the contracted price for the 22 centimeter skew is $65. And so per linear centimeter, silk is about 15% less expensive than the cheapest price with the GPOs that, for the hospital systems. Exafen, I don't actually know the price point for it, but my own personal bias, I'll tell you, is that, whether it's $100 or $10 or $5 it's irrelevant. It's harmful to your patients. Why would you use a product that, at this point, there's, I think, overwhelming evidence is dangerous, and I think it's just a matter of time. I mean, if you were to ask me whether in 5 years we're going to be using cyanoacrylate to cover incisions, I would tell you absolutely not. And having spoken with the executives from the 3 largest manufacturers in the United States, I believe they would all agree. I don't believe that cyanoacrylate is going to be used in medicine at all in 5 years. So that's my personal take on it. I see another question here. Have you used closed incision negative pressure dressings, Pico and PCL? So obviously the Prevena Plus that's made by 3M is the largest manufacturer in any of your studies. Any thoughts behind being cost prohibitive? I think there's excellent data on using negative pressure for closed incision as a technique, as a dressing. The problem is that it's impossible to scale because there's over 1 million cesarean sections per year done in the United States. Yeah, I mean, just imagine the cost to the healthcare system just for cesarean sections. You hook a patient up for 10 days to a negative pressure device. It's hard to shower with it. It takes at least 10 to 15 minutes. I've tried it with a breast reduction. It took me 20 minutes to apply it on a large breast reduction patient. I'm not saying it doesn't work. I think it's an excellent technology, impossible to scale. Would, a high-risk patient undergoing, that's going to be getting chemotherapy, that's, got metastatic disease and is just very high, high risk, should that patient get it? Absolutely. But the average patient, I don't think there's any way.
I just did a last call for questions. I don't see any more here in the chat box. Could I ask you for your closing thoughts, and then we can, we'll leave it there.
I guess my closing thoughts on this are that I would really like to see more quality research on what I consider to be the most effective technique. If you were to combine all of the SCIP initiatives together and look at the risk reduction by following them to a T, I think they will pale in comparison to the risk reduction that you would get with applying the correct dressing to a patient and following, you know, a dressing regimen that's not going to injure patients. You know, again, I'm sort of shocked that, you know, in 2024, we're even having this conversation. There's no standardization. It's a free-for-all. I think there has to be some kind of a standardization that's introduced. You know, I can't think of any other area in medicine where, you know, it's as nebulous as the postoperative dressing regimen, especially since the, you know, the risks that you face are, you know, this is a $10 billion problem per year in the United States. So, you know, my final thought is this is an area where we need to have more research. We need to have more research and development, you know, and the current technologies that exist, I think, are a combination of either being, you know, again, along that lines of that first slide, either antiquated, witchcraft, charlatanism, or just downright dangerous.
And I think what I would add to the research piece, which I think is well said, is that if anyone on the call is interested in doing research, our sister foundation, ACER, does fund studies like this. So that is definitely an avenue to consider for some kind of a grant funding if you're interested in doing research on this or anything else. So with that, I will close and thank everyone on the call and Dr. Mofid for your expertise today. Have a great rest of the day and thank you for sharing what you know.
All right. Thank you, Phaedra, for having me. Thank you all for joining.
Take care.